I think the other area that we probably want to talk about a little bit, as we have more success now treating patients, we are starting to talk also about the era of ruxolitinib failure. And both our institutions had published data on poor outcome for those patients with a median survival of 14 months or less, and patients acquiring other mutations as their disease progress. So when I try to think of where we are moving down the road in clinical trials, I try to think of patients into what we call a primary RUX failure, suboptimal RUX response, and secondary RUX failure. And maybe we can start talking about the suboptimal RUX patients, where I think the trials are heading to kind of the approach of combination therapies with ruxolitinib. And I know this is a huge topic that could take a couple of hours to talk about, and you've led some of those studies. But can you just highlight some of the novel or exciting compounds for you to be combined with ruxolitinib or other JAK2 inhibitors?
Right. So, like you said, suboptimal response to Rux is kind of an emerging concept and has been defined variously in different trials. One definition, for example, that I like was the one used in the parsaclisib trial. This is a PI3 kinase delta inhibitor, where you had to have ruxolitinib for had to have had ruxolitinib for 6 months, and with a stable dose over the preceding 8 weeks, but your spleen had to be either greater than 10 centimeter or 5 to 10 with active symptoms, which tells you that the patient has had an adequate trial of Rux, but still these problems persist. Kind of the idea of suboptimal response. But yes, there are many combinations being looked at, and at the 2019 ASH meeting, there were presentations on the bromodomain inhibitor, CPI 0610, in a trial called the Manifest trial. This trial actually had different arms. You could use the drug alone in patients who were already off ruxolitinib, or you could use it, like you were saying, as an add-on approach in patients deemed to have a suboptimal response to ruxolitinib. So these data clearly show that it's an active drug in terms of spleen and symptoms and anemia improvement. So definitely, I think this is one to watch as the trial matures. They are going to be looking at this drug even in JAK-naive patients as a combination with ruxolitinib. So that's kind of a follow-on from the early data in the suboptimal setting. And then also the first results from the navitoclax study were at ASH 2019, where navitoclax, the BCL2 BCL-XL inhibitor, that, as you know, was kind of fell by the wayside a little bit because of the thrombocytopenia it caused by the on-target inhibition of BCL-XL, might be making a comeback in this space. So nice to see it being developed again. So this was, again, patients who've had 12 weeks of ruxolitinib, suboptimal response, adding the navitoclax to that. And there is some, science behind this. JAK2 has more to do with BCL-XL than BCL2. So there's a feeling that here there's also a biological explanation for why inhibiting BCL-XL may be important. And they saw about a 29% spleen volume reduction at 24 weeks. So again, activity was seen, and these are the first results. So we'll see where we go from here.
Right. And so in practice now in primary or secondary ruxo failure, I think obviously fedratinib is available as a choice for patients if they have like splenomegaly and constitutional symptoms.
Absolutely.
Any novel agents that you think will come as second line after JAK2 inhibitors that you'd like to highlight as well?
Yeah, this is another huge area. There is imetelstat, the telomerase inhibitor. Now, you alluded to both your group and our group publishing that the median survival after Rux discontinuation is 13 to 14 months. However, in the imetelstat trial, where these were all, quote unquote Rux failure patients, they had a median survival of 30 months in the higher dose arm. So that attracted quite a bit of attention. And I believe later the company also looked at your historical data, matched controls from Moffitt, and showed that that survival advantage held up. So that's very intriguing. I don't think we have seen something like that in terms of survival in the post-Rux setting. But then there are others. There is an LSD1 inhibitor now from Imago. It's called IMG 7289. That has been exciting. And there's been other things looked at as well. Our group had looked at a SMAC mimetic called LCL161 from Novartis. Again, activity was seen with all these strategies. Tagraxofusp, which is the drug approved for BPDCN, has also been looked at in post-ruxolitinib myelofibrosis. All of these are active drugs. I think the trials are still early, and we have to see where things go.